Hello everyone. Today let's learn about inherited channelopathies of kidney. There are 4 inherited channelopathies. Those are Barter syndrome, Gietelmann syndrome, Liddell syndrome and fanconis. First, to understand that, let's learn about the normal function of channels in the kidney. So first channel is sodium potassium 2 chloride channel in the thick ascending limb of loop of Henle. What is the normal function of this? The normal function of this is reabsorption of these 3 ions. This channel is in thick ascending limb. Here this is the thick ascending limb. Here you will find this channel. The normal function is reabsorption of sodium, potassium and chloride ions. If sodium also drags water along with it. Okay, this is the normal function. What is happening is reabsorption of these ions. This is the normal function. So there is another channel in distal convoluted tubule. This is sodium chloride channel. What is the normal function of this? Here also the function is reabsorption of sodium and chloride. Naturally sodium drags water along with it. So water is also reabsorbed into the body. The third channel is ENaC channel. It is located in the collecting. Normal function of ENaC channel is sodium and water reabsorption, potassium and hydrogen ions loss into urine. This is the normal function. So now we have seen the normal function of these channels in the nephron. Now we will understand inherited channelopathies. What happens in each syndromes? In Barter syndrome, the channel affected is sodium potassium 2 chloride channel, which is located in the ascending limb of loop of Henle. Okay, we have discussed the normal function. Normal function of this channel is reabsorption of sodium, potassium, chloride and water. If this channel is affected, all these ions and water goes into urine instead of body. Okay, so what happens if a lot of sodium is lost in the urine? Sodium is nothing but salt. We will call it as salt wasting. If lot of potassium is going into the urine, there will be potassium deficiency in the body causing hypokalemia. Okay, sodium drags water along with it. So lot of water is going along with salts. So that leads to diuresis or less water retention in the body. If there is more water retention in the body, it can cause hypertension. All the water is leaving the body, so it will be normotension. Because there is no excess water in the body, so it is normotension. Then hypokalemia always accompanies metabolic alkalosis. Is one more finding here. We have already discussed Barter syndrome is similar to the action of loop diuretics. Same loop diuretics. There is also a famous mnemonic which is called loop loses calcium. That means here there is a lot of calcium going in the urine. So you can see hypercalciuria here. Okay. So this is the very important features of Barter syndrome. And one more important feature is that I'll compare with Gietelmann's and will tell you. So as of now, you remember the features as then Gietelmann syndrome. What is the channel which is blocked in Gietelmann syndrome? Is sodium chloride channel. Sodium is lost in the urine. Along with it, it drags a lot of water into the urine. So all the symptoms are similar. I'll tell the differences also. First, let me tell the similar symptoms. Salt wasting is also here. Hypokalemia is here. Normotension is here. Metabolic alkalosis and hypokalemia we have already discussed. And one more differentiating feature is here you have seen hypercalciuria. Loop loses calcium, but thiazide diuretics will preserve calcium in the body. So you can say hypocalciuria. There is a lot of calcium in the body but not in the urine. Loop loses calcium. That means in loop is nothing but Barter syndrome. So loses calcium into the urine, so it is hypercalciuria. In gentleman's it is hypocalciuria. One more difference is barter's is a severe disease, severe form you can say. That means patient will get affected in the early childhood. But here you can remember it with a mnemonic, gentleman is man. So he'll go until the adult stage, that is until he becomes a man. You can remember with this mnemonic. This is not very severe, that means patient may go into adulthood also. There is a lot, the severity is more in Barter syndrome. Symptoms like mental retardation also you can see in Barter syndrome. Okay, this is very important. The other one is, there are 4 types in Barter syndrome. Type 1, type 2, type 3, type 4. Fourth type is very important to you. You have to learn fourth type. Fourth type is Barton mutation. Fourth type is Barton mutation. It is associated with deafness. This closes the discussion of Barters and Gietelmanns. I hope you have understood it. We will just revise it, everything. Okay. We will revise it very fastly. Barter syndrome is autosomal recessive disease. There is channel is affected in the thick ascending limb of loop of Henle. What is this channel? Sodium potassium 2 chloride channel, similar to the effects of loop diuretics. There are 4 types. Fourth type is important. Type 4 is Barton mutation. It is associated with deafness. Salt wasting, I have already told. Hypercalciuria is seen. Loop loses calcium. And growth retardation and mental retardation will be there in Barter syndrome. Is severe form. Patient may present in childhood only. This you have to remember. Loop loses calcium here. Gietelmann is autosomal recessive again. Same mutation in sodium chloride channel. Transporter in distal convoluted tubule. It is similar to the effect of thiazides. Okay. Which is more common? Gietelmann is more common. Severe form is less common. Defect in the distal convoluted tubule. It causes hypokalemia, metabolic alkalosis, salt wasting. Same, both the symptoms are same. It similar to the action of thiazides. It's milder course. It's not severe course. Whereas Barter is severe clinical course. It presents in early childhood only. It presents late in the onset. Until adulthood, you can remember with the mnemonic, there is man and Gietelmann. Here there is hypercalciuria. Hypercalciuria, lot of calcium in the urine may cause kidney stones. Hypocalciuria is, there is no calcium, there is no loss of calcium in the urine. So that's it. I think you have understood Barter's and Gietelmann syndrome nicely. There should not be any confusion in this because these are very important. The third inherited channelopathy is Liddell syndrome. I'll explain here. We have already discussed that about ENaC channels in collecting ducts. In Liddell syndrome, what happens is there is a gain of function mutation in ENaC channels. It's not loss. Until now we have discussed loss of channelopathy, loss of the function of channels. Now we are discussing about gain of function of ENaC channels. Okay, this is very, very, very important. Gain. What is the normal function of ENaC channels? I have already told you that ENaC channel normal function is sodium and water reabsorption into the body. Reabsorption means into the body. Potassium and hydrogen ions loss into urine. This is the normal function. Now there is gain of function, increase in the function of ENaC channel. That means more sodium and water is reabsorbed. Potassium and hydrogen is lost in the urine. More sodium is lost. That means hypernatremia you can say, or salt retention you can say. More water, that means more water is reabsorbed. That means hypertension. Potassium is lost in the urine. That means hypokalemia. H plus is lost in the urine. That means metabolic alkalosis. These are the features of Liddell syndrome. And it's very important. So, you can be asked like this. Where is this triad seen? It's not triad. Where is this combination seen? Hypertension, hypokalemia, metabolic alkalosis. It is seen in Liddell's. Where is this seen? Normotension, hypokalemia, metabolic alkalosis. This is seen in gietelmann and barter. If you want to differentiate, gietelmann has hypocalciuria, barter has hypercalciuria. See what is given in the text. Liddell syndrome is autosomal dominant. Until now we have discussed both barter and gietelmann are autosomal recessive. There is gain of function in intact channels similar to the effects of aldosterone, hypertension, hypokalemic metabolic alkalosis. And now we will discuss about fanconis syndrome here only. Fanconis syndrome is nothing. You need not remember a lot about fanconis syndrome. Fanconis syndrome is a defect in proximal convoluted tubule. Generally, in proximal convoluted tubule, there is a lot of reabsorption of solutes. Like majority of reabsorption of solutes occur in proximal convoluted tubule only. Bicarbonate, glucose, amino acids, phosphate, everything gets reabsorbed in the proximal tubule. In Fanconi's syndrome, the proximal tubule function is lost. So what happens? All ions will not get reabsorbed. Everything will go into the urine along with a lot of water also. So what is the presentation? Polyuria. A lot of water is wasted in the urine. And lot of glucose is sent in the urine. Lot of glucose is gone in the urine. Lot of urine is also there. Bicarbonate is lost in the urine. So just now you remember it now, as of now. In proximal tubule, due to the loss of bicarbonate is lost. That means alkali is lost. That means you are getting acidosis. This is type 2 renal tubular acidosis in Fanconi's anemia. This is an MCQ. You have to remember it. Everything is lost. Everything will be hypo only. Hypokalemia, hypophosphatemia. Amino acids are gone in the urine. Everything. So just remember the causes. Inherited causes. Cystinosis, very important cause which you have to remember is tenofovir is the drug